Well, thank you so much for the invitation to talk to this group about what it's like to participate in a clinical trial. I have to say, for people that have a diagnosis of AML, this often is a part of your treatment. And I think it's incredibly important to understand the purpose of a clinical trial and what you can expect. So I think this is an incredibly important topic, and I'm really excited to be here. I think we can go on to the next slide. Excellent. I will say I'm coming to you from Wisconsin, which is part of the United States. So a lot of my information is very US centric. So there may be some differences between the US and some of the European countries, but I think the concepts are quite consistent. So just to begin with, what exactly is a clinical trial? If you go to the National Institutes of Health, they actually give a formal definition for a clinical trial. And what this is a research study in which one or more human subjects are prospectively assigned to one or more interventions in order to determine the effects of those interventions on some form of health. It's a very formal definition, but really it means that a person agrees to be in a research study in which a question is being asked and answered. I think the logical question most people will ask is, well, what type of questions could these be? And I do think this is an important question to ask yourself as you are considering participation or advising friends and family about participation in a clinical trial. What is the basis or the rationale for the trial they're being offered? Is it to understand about how the disease works? And since this is really an AML focused group, we'll talk about acute myeloid leukemia as the primary disease in this instance. Is it to learn more about how AML develops and progresses? Is it to test a specific intervention, so some sort of treatment to see if it helps? Or is there some other goal for this clinical trial? So I think this is a very important first question to ask ourselves. We can go on to the next slide. Oh, I think you can click again. So just briefly, my conflicts of interest. So I am actually the member of an IRB, and in a few slides, we'll learn exactly what that is. So I'm part of a group of investigators who help review clinical trials to see if they're safe and appropriate for people who participate in the trial. I don't have any other formal disclosures, but I do regularly offer clinical trials to my patients. So I'll put that in there. All right. So there are 3 phases of clinical trials. And for anyone who is considering a clinical trial, when you receive a consent form, often the name of the trial will include the phase in its title. So it's good to be aware of what these are, because these can help you understand what to expect from the trial that you're being offered or considering. So phase 1 trial is really the first step in testing a new treatment. Often there is a dose escalation, meaning the drug will be given to people who participate in the trial at a very low dose. And then as we see whether there are side effects that we didn't expect or how well it's tolerated, the dose may escalate in a very predictable, ordered fashion. Often when people are in a phase 1 trial, they receive a set dose, and that's the final dose that they received. The goal of a phase 1 trial really is to test the safety of brand new interventions or drugs, to look for side effects, and hopefully to identify a best dose based on potential toxicities. You'll notice I'm not really talking here about efficacy. So I'm not talking about testing to see if an intervention accomplishes the goal of the overall, reason for trying this medicine. It may help people, it may not. It usually involves a small number of patients, and frequently it's offered in a setting where people have tried other treatments and are looking for new agents, new drugs. So things that we can't necessarily just go off the shelf and pull down. So this is a very early stage trial. All right, we can go on to the next slide, which is phase 2. So in phase 2 trials, we're starting to now ask whether a treatment actually works for AML. We're certainly also gathering more information about the safety of the treatment or how the treatment affects more than just people's bone marrow or AML, but the rest of their body. Phase 2 trials often involve more patients than a phase 1 trial. At this point, we've identified what the best dose is based on safety information from a phase 1 trial. For someone in a phase 2 trial, the consent form may include a little more detail about what to expect in terms of side effects from a drug. We probably still don't know all the potential side effects because, again, a phase 1, that drug has really been offered to a small number of people. So phase 2 is often something we call a dose expansion. So we're offering this medicine to more people to see if it might work and if there are any toxicities that we missed or didn't find out about in the early phase trial. All right, for phase 3, this is typically the final phase of testing. It's often a much bigger trial. And these trials are typically designed to compare a newer treatment in comparison to a standard treatment. So for instance, it may be asking, well, is this, we'll say for AML, is a standard doublet containing a hypomethylating agent and venetoclax, is this as good as those two agents plus a novel therapy? Trials typically only go on to phase 3 once they've completed phase 1 and phase 2 or some combination thereof. So it's very likely that if someone is involved in a phase 3 trial, there may be a randomization component. So that means somewhere typically in a, usually your doctor doesn't get to pick, there is some decision made in terms of whether a participant gets the standard of care or gets the standard of care with the novel trial or the novel trial option. And so this is typically the last phase of a clinical trial before they approach whatever the governing body is for approval. So we can go on. So I mentioned approval for clinical trials. How are they regulated? So in the United States, there's a collection of agencies, or one agency and then several smaller boards that help oversee clinical trials. So the most kind of the overarching group is the Food and Drug Administration, or FDA. So this is a government agency many folks in the US will have heard of. And its mission is really to protect public health by making sure that drugs, medical devices, and equipment are both safe and effective. They also ensure that food and other things are safe and truthfully labeled. So they are the agency that the study group or study team will petition or ask for something called an IND, or new drug approval, or new drug intervention, to approve the start of the trial with an agent, a new drug. The forms and the amount of information that a study has to supply to the FDA, or an investigator has to supply to the FDA for an IND to be granted, is pretty extensive. And the FDA helps determine whether sufficient preclinical testing. So has it been tested enough in a laboratory for the investigator to reasonably believe that it is a safe agent to test in people? So we can go on to the next slide. So in kind of a greenish color, we've got an IRB, or an institutional review board. So this is a fairly important group within a clinical trial. It's a group of typically scientists, clinicians, often clergy, and patient advocates. So you'll notice people who are in healthcare and people who are impacted by healthcare. And their goal is to review a prospective clinical trial. They review everything about the trial protocol, how the medicines are handled, how participants are approached, and even the nitty-gritty of the consent form to see if the trial is being performed and offered in a way that guarantees maximal protection for the people who agree to take part in this trial. Every clinical trial is reviewed by an institutional review board before it begins and regularly thereafter. So often there are yearly reviews of each protocol, and should a protocol be modified or amended, there's subsequent reviews that may happen throughout the year as well. So we can go on to the next slide, which deals with the data and safety monitoring boards. So these are yet a third group. It's an impartial group that oversees clinical trials, and they really are responsible for looking at the trial, any interval data analysis, really providing scientific and safety advice about the trial. They will generate a pretty extensive report, and that's then shared back with the investigators, often the FDA and often the IRB that oversees a trial. So they're an incredibly important group. These are people who have no role in a clinical trial, in the clinical trial whatsoever. And their sole goal is to make sure that the trial should continue to be open and available, that the question hasn't already been answered, or that there aren't substantive changes that should be made to the trial based on what an investigative team has learned already. And so all of this, goes into this thing called a good clinical practice. And this really is an international set of guidelines, and they're developed to help make sure that a clinical trial is done correctly, accurately, that the results are reliable, and most importantly, that patients or individuals who decide to participate are protected. It covers nearly all aspects of a clinical trial, the way it's designed, the way it's conducted, performed, monitored, kind of re-reviewed, analyzed, everything. So this is really the end goal for a clinical trial in terms of safety and regulation. So what ethical principles drive clinical trial development? In the US, a lot of or pretty much all of our modern clinical trial structure can in one way trace back to this thing called the Belmont Report. It's a series of ethical principles and guidelines for the protection of human subjects of research. It was developed back in the mid-1900s, unfortunately in 1976, unfortunately following the Tuskegee syphilis trials in the US that are widely appreciated as being wildly unethical. And the goal was to really understand what should be the guiding ethical principles for a clinical trial. So any clinical trial, no matter what the disease it is trying to address, has to respect and pay attention to these primary principles. So these are things like respect for persons. So this means people have autonomy to decide whether or not they participate in a clinical trial. No one should be forced to be in a clinical trial against their will. Things like beneficence. So this means that clinical trials are designed in a way that maximizes potential benefit for its participants and minimizes potential risk. And then justice. So this means are people being approached equally for participation in the trial? Essentially, it's unethical to take a population of people and offer and kind of mandate that they be part of a clinical trial, or to specifically call them out and kind of try to have inappropriate compensations for being in a clinical trial. So an example could be, going to a group of individuals who are incarcerated and saying, if you agree to be in this trial, will modify your living conditions. That would not be ethical under any circumstance, according to the Belmont Report, and I think according to most people. The Belmont Report is the basis for the Common Rule, or now the Revised Common Rule, which is the official federal policy in the US that protects participants in research. Okay. So that's a lot of background about kind of the ethics and the ethical framework for clinical trials in general. But I think for this group, perhaps a more important question is, why are clinical trials important in AML? Well, this timeline really goes from the early 1970s into the modern era, and really outlines kind of the evolution of the standard of care therapies, or FDA-approved therapies for AML in the US. So back in the 1970s, we started to use this 7+3, or a combination of cytarabine and daunorubicin, so 2 cytotoxic chemotherapy drugs. And honestly, for a good 30 years, this was the standard of care. So obviously this timeline is not drawn to scale, but we had a really long time without a lot of substantive advances in AML. I think we did a lot with clinical trials to optimize the way standard induction treatment was administered, but probably didn't add a lot in terms of new therapies. But in the 2000s, we started to identify some novel agents, targeted therapy in this gemtuzumab, or Mylotarg. We started to look at other options for daunorubicin, or the anthracycline, in the 7+3 treatment. We actually looked back at some data about how we were giving gemtuzumab and realized that the way it was being administered to adults early on actually led to a lot of hepatotoxicity, and that this was not acceptable. And so it was actually, this drug was withdrawn from the market. And this really was because of continued safety monitoring of this new agent that had been approved by the FDA. In 2017, we had a lot of new agents approved. And again, through new clinical trials, we realized that gemtuzumab dosing could be modified and incorporated safely into specific circumstances. As we started to understand AML biology more, because patients were willing to donate samples of their bone marrow and their blood, we started to learn more about the genetics of AML. And that allowed investigators to design targeted treatments that could be used in specific cases based on the genetic markers that some people's leukemia may have. And so that's where we've really added a lot of new agents between 2017 and 2018. And then there was an appreciation that some folks with AML do really well with the intensive treatments, and some people don't do as well with that. And there was a lot of work to try and optimize how some of these less toxic combinations could be given. And that led to approval of these combination therapies with things like hypomethylating drugs and venetoclax. So really, honestly, in the last 6 to 7 years, the way in which we're able to treat AML has changed in a huge way. And this is all because of clinical trials. I think, just making guesses or going from how one individual does, you really can miss a lot of important information about a new treatment or a new treatment combination. And in order to make sure that that information is disseminated correctly and that we really understand how to safely give new and better treatments, it's absolutely critical that this be done in an ethical, organized, reproducible way. And so that's really what clinical trials are. And I think it's a really exciting time because there's new drugs being tested right now. And really, this is an ongoing area of investigation to try and figure out how to be able to successfully treat and get more and more people with AML into remission for longer and longer periods of time. So clinical trials are incredibly important in AML. It's, a relatively uncommon disease unless one is, in a treatment center like ours or many across the country and the nation where there are a collection of resources pooled to help take care of people with AML. And so again, bringing folks together across multiple institutions, multiple locations, really is critical through a clinical trial network to be able to treat people with these diseases, such as yourself or your family members. All right, we can go on to the next slide. So what is the process for enrolling in a clinical trial? And this may be one you can click through. Yep. So the first step really is diagnosis. There's lots of clinical trials out there really targeting different diseases and people at different stages of their disease. So it's really important to define what disease is being treated. So that's where I start with diagnosis. The next is trial identification. So your treating clinician will know you and will say, all right, this is what disease my patient has, and let's look at clinical trials that are available at our location or are available in a reasonable area for our patient. And let's see what options we have. Next, we'll go on to a preliminary screening. And so this may be something that happens behind the scenes. Every clinical trial lists what we call inclusion criteria and exclusion criteria. And really, it's just a list of things that the investigative team who designs a trial thinks are important for knowing who can most safely participate in a particular clinical trial. So these screenings may happen behind the scenes simply with a review of clinical information. It may be something that a prospective participant in a trial actually signs a consent form for preliminary screening. So I'm thinking of one particular trial we have running right now in the US where patients actually consent to undergo screening for a FLT3 mutation, so a very specific genetic mutation in their AML. And they basically are saying, all right, I'm giving permission for this big study team to test my leukemia to see if it has a particular mutation. And that's really all the screening form says. There is a subsequent informed consent, and the patient or the subject would then decide, once those results are back, do they want to continue and actually move into the treatment arm of the clinical trial? So it can take multiple shapes. Informed consent really is the most incredibly critical aspect of participating in or enrolling in a clinical trial. It's a discussion that needs to happen between a potential participant and either their treating physician, or I know in some areas of the country and the world, it's not the treating physician, but it's actually a member of the clinical trial team. And the study itself is reviewed in pretty great detail. And it's important to make sure that the potential participant really understands why they're being asked to be in a specific clinical trial and what's involved in the participating in the clinical trial and what is the potential benefit or not to them in participating in the clinical trial. At the end of this discussion, then a participant can decide whether or not they'd like to participate and typically indicate that by signing an informed consent form. All right, so what happens when someone participates in a clinical trial? I have to say it can be, I put a calendar up here. I think one of the most challenging aspects for trial participants really can be managing the calendar. And it's typically not the participant who has to do a lot of the managing, but it's good to be aware of what you're being asked to do. So as I alluded to, there may be certain studies that a patient needs to complete before official enrollment. So these may be things like blood samples, bone marrow testing, cardiac or heart function examination. So those will be scheduled within the context of the clinical trial. Next, it's good to know that sometimes people agree to be in a clinical trial. They give their informed consent, but then there may be additional tests that need to happen to determine if someone is if their health meets the criteria that the study team has outlined for safe participation in a trial. So it's good to be aware that once you sign consent, there still may be a final enrollment stage, and not everyone may ultimately end up enrolling after they start a clinical trial. Next, you may get to meet and work with 2 new groups of people that you may not have met as part of your healthcare team before this. So these are people like clinical research coordinators and clinical research nurses. So clinical research coordinators are typically people with a background in science and medicine. They are often not MDs, but they may have other bachelor's or public health degrees. They're incredibly knowledgeable about the clinical trial and about how the clinical trial is safely administered and results documented. They'll get to know you pretty well and be some of the folks that help with scheduling various study-specific activities. The clinical research nurses are also a similar group, but they have a nursing background. So they may do a little bit more with you in terms of lab draws, blood tests, things like that. I think it's good to know that once you enroll in a clinical trial, you don't have to be in a clinical trial forever. You will regularly review your participation on your own and with your doctor. And hopefully everything is going well with the clinical trial, but there may be things that happen along the way. Perhaps your AML is in remission and it's time to move into a bone marrow transplant. Or maybe you and your doctor decide that the clinical trial really isn't the right fit, or it didn't have the desired outcome for you. And so then you would decide, and your doctor would help decide that it's time to exit the clinical trial. So next. So what could you be asked to do if you're participating in a clinical trial? Typically, most participants will be asked to have a history and physical exam completed by either their doctor or the study doctor. This is typically not a huge additional component to your regular clinical care, but it's something to know that may be recorded within the context of the trial. You may have to have additional blood or bone marrow tests done. Sometimes these are samples that are collected at the same time as blood or bone marrow that would be collected as part of your regular care. It may be extra samples that are requested. So it's good to know what you're going to be asked to contribute. All right. You may have to have additional heart function tests. Many new drugs, we don't fully know always, especially in an early phase 1, how they could impact heart function or conduction of current through the heart. And so it's really important to have these baseline tests evaluated. Sometimes there's also criteria in terms of how well we want someone's heart to function in order to safely participate in a clinical trial. So these are also commonly included. In addition, many clinical trials these days will include patient journals or patient diaries to understand what participant experience is. It's really critical. It helps us understand not just what you tell us when you come to visit us in clinic or in the hospital about your symptoms, but also really how it's impacting your daily life. And that sort of information is absolutely critical to helping design kind of the final regimens that some of these newer drugs can be a part of. Also to help know how to coach and guide future patients who may be part of the trial. And then the big one, honestly, is that some clinical trials will ask you to spend additional time at the treating hospital or in clinic for other visits associated with the study. And this sounds like it's maybe not going to be that big of a deal, but it really can be. For some early phase trials, we may ask participants to allow us to draw their blood at regular times over the course of 24 hours after a drug is administered so that we can understand how quickly a new medicine is cleared from their blood. Sometimes that means patients are with us in our outpatient hospital for the better part of a day. Sometimes it means patients actually are admitted to the hospital for these tests and for kind of safety monitoring and intervention. And so I'll speak about where I live, which is in Wisconsin, and we're heading into winter right now. And so this is especially important for us to talk about to our patients about, because for many of our patients, they can live 2 and 3 hours away from our treatment center. And so if we're asking them to be in a trial where they're going to need to drive to us in the snow and ice 3 and 4 times a week to be part of the trial, they really need to know that at the beginning so that they don't find themselves in the middle of something that pretty quickly they realize is just not feasible. We're fortunate that we've been able to actually build a small, almost like a hotel right next to our hospital. So sometimes patients will stay there if they're in a clinical trial that requires a lot of visits and they live far away. So these are important things to really understand and figure out what your plan is going to be if you're participating in a trial that requires frequent visits, especially if you don't live immediately near your treatment center. All right, next slide. So this gets us to what factors should patients consider when deciding to participate in a clinical trial. All right. So the first thing, what is the phase and goal of the clinical trial available to them? We already talked a lot about the phases 1, 2, and 3, but is the goal of the trial to find the best dose of the new drug? Meaning you could be receiving a dose that's quite low, or you could be nearing the dose that we think or hope will be the most effective or best tolerated dose. So it's just important to know where you are. Or you could be in a phase 3 trial, and there may be a randomization component. And so you don't know which treatment you would be receiving, the standard of care versus the newer regimen. So it's very important to know the goal of the trial. Where is the trial being offered? So I think we've talked about this quite a bit now, but where is it being offered? Another question may be, is the trial offered other places closer to where you live if your treatment center isn't right nearby? Or if you move, can your participation in this trial be relocated? Next, what are your goals and motivation for participating in a clinical trial? I've had many patients who say, they had been blood donors once upon a time, or their family members were blood donors, and they're incredibly grateful for the blood donations of other people. But because they have leukemia, they can't be a blood donor anymore. And it's a very altruistic thing to do. And so I have many patients who say, if you have a clinical trial where they want to study my blood or bone marrow to help other people in the future, that's something I find very meaningful to me and I want to participate in. Some people, I think probably anyone with a diagnosis of acute leukemia wants to find out how to get this disease to go away so that they can go on to live a full and happy, healthy life. But it's really helpful to understand going into it, what is your goal for participating? And then what time is necessary to participate in the trial? Is this something where you'll have one visit every month? Or is this something where for the better part of, the workday for weeks on end, you'll be into this study site and really take a realistic look at your kind of work-life balance, or how you feel in terms of degree of fatigue that often comes with AML, and is this something that you really want to commit to, or is feasible for you? And I alluded to some studies that will include something called a bank or biobank. Are you comfortable with samples of your blood or bone marrow being saved for future researchers to study? This is often a component of clinical trials. It helps investigators go back and understand when a drug works really well. Were there features of a leukemia that helped it to work really well, or the opposite? And there may even be studies or research people want to do unrelated to the trial that you participated in, but the ability to access your blood or bone marrow samples may be incredibly helpful for them designing the next era and the next generation of treatment. But is that something that you're comfortable contributing samples to? And the answer may be yes, and the answer may be no. All right. And then the final word on that. So as part of your clinical trial that you're participating in, will any genetic studies be done? So in the US, we have something called the GINA Act, or Genetic Non-Discrimination Act. And this is important to be aware of. If there are genetic studies being done on your blood or bone marrow sample, language reviewing the GINA will be in the consent form. And really what it says is that insurance companies and treatment groups are not, and potential employers are not allowed to discriminate against you based on genetic information. And so it's just something to be aware of as we have entered the age in which people's AML can be sequenced relatively quickly, relatively efficiently, and suddenly we have information about a person's AML. We may actually have information about your cells that are not part of your AML. And this may give us clues to diseases, inherited diseases or diseases that can be passed down to family members. And so it is very important to us that patients and subjects be aware of this and to know that these studies are being done. All right. And then what questions are important to ask your healthcare provider? So this is someone who you'll be spending some time with discussing the trial as part of this informed consent process. So you want to know, what are the risks to participation? And these can be health risks, privacy risks, financial risks. So we've talked about health risks a little, side effects or study-related procedures, but then the risk of privacy is a big one to think about. When someone signs up for a clinical trial, this means there's a lot of individuals, or maybe not a lot, we try to keep it as small as possible, but we want to have the right number of individuals overseeing your clinical information and healthcare to make sure that the trial is being done safely for you and that all of your results are being recorded and collated so that we can interpret the results of the trial. Most institutions, every institution has to have pretty significant strategies in place to protect participants' privacy, but no system is 100% fail-safe. And so unfortunately, from time to time, there are risks or loss of privacy in healthcare data and information. So it's good to understand what those risks are for the trial you're looking at. And then, are there potential financial burdens to participating? And these are things that your treating physician and team should be able to discuss with you. Then what are the benefits? And we talked about these already. And what are the time and experiential commitments to participation? And we talked about these already. But your healthcare provider is a good one to ask. So if you're interested, or you have a family member or friend who's interested in participating in a clinical trial about acute myeloid leukemia or another disease, where can you go to find out what is available? In the US, at least, it's this clinicaltrials.gov website is a good place to start. And you just kind of work your way through the fields and you will slowly find a collection of clinical trials that are open related to your particular disease. Your home institution may have other portals. I know we have one at the Medical College of Wisconsin that's available kind of on a limited scope to the public, and then a little more extensive scope in terms of disease details of trials to our internal organization. So there's lots of resources out on the web, and these will tell you what is the trial, kind of the basic outline, and where is the trial being offered. All right. So how can patient care and treatment options for AML be improved by participation? So again, I think these are things we've covered, but really it can help add general knowledge about AML in order to design new treatments. It's important because, as we reviewed, some of what was experimental years ago is now our standard of care, and we want to continue to improve on that. And the only way we have to do that is with clinical trials. You can participate in patient advocacy and education groups, just like this one, this No AML group. You could consider being a peer resource for other individuals with AML. And something I encourage you to think about, you could actually participate as a patient advocate on some of the local institutional review boards. All institutional review boards have to include patient advocates or non-clinical folks who have some insight into healthcare or how it's impacted them and their family. And that's a wonderful way to contribute. All right. As you can imagine, and as I alluded to, AML is a relatively uncommon disease, and we want to make sure everyone being treated for AML has access to all of the latest information and updates about new treatments that are being tested in clinical trials. And so we do that by several methods. So first is clinical trial collaborations. So these are things like cooperative groups in the United States and Europe. There are these trial consortiums. So institutions throughout the country come together. Treatment providers decide what is the next most important question to ask in order to improve treatment for a specific disease, and they design trials. There may be multi-institution trials that are not run through one of these cooperative groups, but maybe multiple institutions in an area kind of band together so that they can offer the same trial to multiple participants. And then there may be company-sponsored trials that could be offered through multiple institutions. Institutions will start a trial, but then we may rely on some of the support and expertise from companies to kind of continue the trial work. There's robust data sharing, and this is a huge component of what we do. Just because the trial is done doesn't mean that that's the end. We have to share our results through national meetings. This may be, and this includes positive and negative results. So something worked or something didn't improve upon standard of care. We publish results in peer-reviewed journals. So that means we describe our trial, we describe the results, and then our peers actually read our results and make sure that we've accurately described our study, our results, and the interpretation. So this peer review process is incredibly critical. And then some data may actually become publicly accessible, depending on how data sharing works for each trial. So the process, it's not just that we do these studies and then we know the information and we keep it secret. This dissemination of information is incredibly important. All right. And so with that, I will end, but with a huge thank you to my home institutions, my primary institution being the Medical College of Wisconsin, and secondary being Versity, which is a transfusion medicine organization and research institute. I'd like to thank No AML for inviting me to speak. And honestly, my biggest thanks goes to all of my patients and their families who have participated in clinical trials and really helped identify new treatments. And with that, I will end. Any questions?
I'm Charlie Craddock. I'm a clinician and a trialist, and I just wanted to congratulate Karen. I think that's the best talk I've ever heard on the importance and practice of clinical trials in any disease.
Thank you. That's incredibly kind.
It's just so elegant and lucid, and I think you focused on all the really important questions for patients. The only couple of points I suppose I would add, but you didn't have time to cover them, is when we offer patients a clinical trial, one of the questions, of course, is what happens if I get the control arm? And I think there's some really fascinating data out there in many diseases, not just in blood cancers, but actually in diseases like diabetes and rheumatology, that the really interesting thing about clinical trials is that whichever arm you're on, you nearly always do better than if you weren't on a trial. And that's fascinating. Some of it may be about patient selection, but it may also be about this augmented team. And I think patients find that, and also you pointed out, Karen, the altruism. find, you know, that's a really important driver. And then the second point I'd make is sort of strategically, the reason we have these new therapies is because as a series of nations, we've spent trillions of dollars and pounds and euros on scientific advance to develop these new treatments. And one of the real paradoxes when you stand back and you look at a disease where there has certainly been progress, like AML, well, there's certainly been progress, but still quite a lot of patients don't get a great outcome, is you ask yourself, why as a community we don't invest more money in clinical trials? There aren't more research nurses at institutions. That's often a rate limiting step. And actually, interestingly, it's a separate point, I suppose, Karen. But why do we kind of have such an old-fashioned trials delivery vehicle? I mean, the way we do trials is about the same as the 1990s. We're all going to be driving electric cars in 5 years. So I think there's also a point that if I was a patient, I would be wanting to see investment into a clinical trials infrastructure that almost offers my participation in a clinical trial as a default, as my right. So those were my only 2 points, but really it was wonderfully informative and I wanted to thank you.
Oh, thank you. I have to say, those are incredibly important points you bring up. I know there's new trials being developed where a participant could enter the trial, and then I think it's a really neat design where as we learn more about someone's leukemia and we learn more about some of the genetic changes, people can sort of move into the correct trial for them without quite as much overhead. So I think some of those are really neat, some of the MyeloMatch infrastructure that's being built. But yeah, having a solid clinical research nurse cohort is a huge impediment over here. We're really lucky for the folks that we have working with us, but yeah, I think most sites could use more. And yeah, in terms of your first point being the significance of the control arm, and, you know, one of the hardest things when I go to talk to someone about a clinical trial is discussing, you know, this randomization or the control arm or standard of care versus the trial with the newer agent included. And it sounds like, oh, I definitely would want the newer agent. And if I got the standard of care, I'd be disappointed. And I think it would be hard for me to hear as the potential participant, but I genuinely believe, and it's always as clear as we can make it, that we don't know the answer to which is better. And if we knew the answer, there wouldn't be a trial. The answer would be known. And there are, unfortunately, numerous instances where, you know, we studied a new intervention and found that it was either the same or not quite as good as what we were doing. Just like there are numerous instances where it's been found to be better. And if we knew, we wouldn't be doing the trial. But I think that's a hard one to take in when you're considering entering a trial as a participant.